Hi, thank you so much for joining us for a two-part webinar series brought to you to talk about urinary incontinence in women. In part one, we will be focusing on the epidemiology, screening, and care management when it comes to women with urinary incontinence. I'm Dr. Jessica McKinney. I'm a physical therapist and the VP of Medical Affairs and Clinical Advocacy at Renovia Inc. And I'm joined by my colleague, Dr. Laura Kaiser, who is also a doctor of physical therapy, who holds a public health degree as well. And she's our senior manager of medical affairs.
Thanks, Jessica.
Go to the next slide. So this slide is just a section for us to pause for a moment as you can read through, indicating that all of the content of these slides are intended for healthcare professionals only. They are reference materials and not designed as any type of medical advice. Furthermore, the indication for the LEVA public health system is listed on the lower half of this slide. The LEVA public health system is intended for strengthening the pelvic floor muscles and rehabilitation and training of the pelvic floor muscles for the treatment of stress, mixed, and mild to moderate urgency incontinence, including overactive bladder in women. Next slide.
Great, so I'll pick it up here. So you can see the objectives listed on the slide here. First, we're going to talk a little bit about the epidemiology of urinary incontinence, provide some definitions about the three primary subtypes, and then look at risk factors, barriers to treatment, and screening guidelines. And then from there, we'll do a dive into the evaluation and treatment pathway. So broadly, female pelvic floor disorders affect millions of women in the United States. There's been some variable definitions of pelvic floor disorders. So we have some variable prevalence estimates, which you can see listed on the slide here. Today, we're primarily going to focus on urinary incontinence, which is one of the main female pelvic floor disorders affecting over half of women. There are estimates that about a quarter of women in the United States have at least one pelvic floor disorder, so we do know that they tend to co-occur. These pelvic floor disorders cost millions of dollars. You can see the 2006 estimate of over $400 million in healthcare costs, which has only risen since that time. We do know that pelvic floor disorders tend to co-occur, as I mentioned, and then they tend to progress or worsen in their severity over time. And we also, there's some limited, but there is evidence to show that there are disparities by race, ethnicity, and other factors. So when we think about urinary incontinence, certainly there can be a variety of reasons that someone develops urinary incontinence, but about 95% of women will present with one of the three main subtypes that you see listed on the slide here. So stress and urinary incontinence refers to the involuntary loss of urine that occurs with any type of physical exertion, coughing, laughing, sneezing, etc. Urgency urinary incontinence is the involuntary loss of urine that occurs with a strong and sudden urge to urinate. And there we also see overactive bladder, which can be accompanied by urgency urinary incontinence, though not always. Overactive bladder syndrome is characterized by urinary urgency and frequency, and often occurs with nocturia as well. And then finally, mixed urinary incontinence is a combination of both stress and urgency symptoms. Often you'll see someone with mixed incontinence labeled either stress dominant or urgency dominant, depending on the primary bothersome symptom. So when we look at the epidemiology of urinary incontinence, over 20 million women in the United States report bothersome urinary incontinence, and that number is projected to exceed 28 million by 2050. And this has to do with the size of the aging demographic in our country, as well as the obesity epidemic, which are both independent risk factors for urinary incontinence. In terms of incidence, you can actually see it's pretty stable across various life stages. So around 21% during pregnancy, similar estimates for the postpartum period, and then even later in midlife, around 21% in terms of number of new cases emerging. Something that's important to note is that urinary incontinence often relapses and remits over time. So a woman may be bothered by incontinence either in the pregnancy and postpartum period, and then her symptoms go away, and then they return. They often will return at midlife and can kind of come and go over a period of months or even years. It's important to note that women who do have a history of urinary incontinence have a 30 times greater odds of developing incontinence later in life. Um, so there are a lot of opportunities where we can intervene to address these symptoms with this in mind, that this is sort of a progressive or certainly a relapsing disease. There are a variety of risk factors for developing urinary incontinence. The primary risk factors are both pregnancy and childbirth, which are both independent risk factors. Certainly, mode of delivery can impact whether or not a woman develops UI, so a cesarean section versus a vaginal birth, and a vaginal birth that's instrumented would place a woman at a higher risk of developing UI. There's a variety of comorbid conditions that accompany incontinence as well, such as obesity, constipation, decline in functional status, as well as things like respiratory disorders, depression, diabetes, and others. Smoking is also a risk factor, particularly for urgency incontinence, and high impact exercise as well. When we think about the costs of urinary incontinence, they are quite significant, both to the individual and to our health system. So from an economic perspective, it's been demonstrated that there's significantly higher healthcare resource utilization and costs associated with managing urinary incontinence, and just overall associated with managing the sort of health of women with urinary incontinence. In terms of psychosocial costs, women with UI have greater rates of depression, anxiety, social isolation. They tend to score lower on quality of life surveys. And then from a physical standpoint, they're more likely to experience disability, more likely to reduce physical activity over time, and they experience a greater and faster functional decline. Having urinary incontinence is also a risk factor for a variety of things, as you see on the slide here. 30% greater risk of hospitalization, more likely to be admitted to a nursing facility, more likely to experience falls, 3 times greater odds of functional dependence, and more likely to require a caregiver to help with either activities of daily living or instrumental activities of daily living. So all of this, I think, contributes to sort of the next our next topic of focus, which is screening guidelines for urinary incontinence. So we can see the sheer numbers of women with UI sort of warrant this as a public health problem. And when we look at the number of women with symptoms and the number who are seeking treatment, the numbers don't match up. So only about a quarter of women with urinary incontinence are seeking treatment. Women to wait on an average of 6 years before they talk to their healthcare provider about their incontinence. And so there's a lot of missed opportunities where we could potentially intervene to help these women. There's a variety of barriers to care seeking. At the individual level, women may not seek care because they're embarrassed about their condition. They lack knowledge that there are treatment options. They may feel that their symptoms have not gotten bad enough, they're not severe enough. And many women report they had not been willing to bring it up to their provider, and they were never asked by their provider explicitly. There's also barriers to care on the institutional side. So from the healthcare provider standpoint, there's time constraints and competing priorities. We know there's an insufficient health workforce to provide women's health care. Certainly economic barriers as well as sociocultural barriers that can limit patient accessibility to a variety of health services. So with this in mind, in 2018, both the American College of OBGYNs and the Women's Preventative Service Initiative put forth guidelines around screening for urinary incontinence. And both professional societies and initiatives recommend annual screening for women for UI. The WPSI recommends that this is included as part of the Well Woman exam. And ACOG also issued additional guidelines to screen postpartum women for urinary and fecal incontinence, and then to move them along to treatment if warranted. So this is just a reminder that there are a variety of screening tools available. both ACOG and the Women's Preventive Service Initiative, among other professional societies, recommend that we use validated screening tools. So survey instruments and other tools that have been demonstrated to be reliable and valid and sensitive. So meaning that they're likely to correctly identify a patient that has the condition. Though certainly in many clinical settings, non-validated tools have been used and certainly can be acceptable for some purposes. One example, and I think among the recommended UI screening tools, the 3IQ, or the 3 Incontinence Questionnaire, is one of the shortest screening tools that can, it's just 3 questions, which you see listed here, and that can lead to a provisional diagnosis of stress, urgency, or mixed incontinence, or it can identify women that don't fall into one of those buckets and that may need some further workup. These screening tools can be useful both for identifying patients with UI, though it's important to also remember that these are not necessarily meant to diagnose or treat patients or even to track outcomes over time. So there's other survey tools that we'll talk about later that would be more useful in terms of monitoring someone's response to treatment over time.
Great, thanks. So I'll step in here and say, once we get to the end of urinary incontinence screening, we'd move into evaluation. And so the components of evaluation for urinary incontinence are depicted in the graphic on this screen. In the central box, you see that this typically involves a physical examination, perhaps a more detailed symptom history than what would be done just on a screening questionnaire, urinalysis, calculation of post-void residual, and the use of additional validated symptom and quality of life questionnaires, as well as perhaps a bladder diary to track input, output, and frequency of leaks. In the course of this, the healthcare professional is going to be seeking to identify transient causes of the urinary incontinence that could be addressed, and determine if it's perhaps a more complicated manifestation and if a specialist referral would be warranted for things such as suspected neurologic reasons, history of prior surgery, or hematuria. Once that has proceeded, as you heard earlier in Dr. Kaiser's slides, she said that about 95% of ambulatory women have stress, mixed, or urgency urinary incontinence. And so the graphic on this screen kind of picks up at that point after the evaluation, after the identification of one of these 3 subtypes of urinary incontinence. We see that at the top. And now all 3 of these types flow into the same first line care for women. So first line care for urinary incontinence has pelvic floor muscle training as its cornerstone. This is complemented by and really supported by additional behavioral modifications that may include weight loss, bladder training, and fluid management. And often this is done in the context of supervised care, where there is a healthcare professional responsible for teaching someone how to do pelvic floor muscle training and overseeing that program for them for a period of many weeks or up to 3 or more months. It's after the implementation of first line care that the treatment pathway starts to diverge according to predominant or sole symptoms. So on the left-hand side, those with stress urinary incontinence who would progress beyond first line care could encounter advanced therapies. This may include the use of vaginal estrogen, continence support pessaries, or surgical interventions or other procedures such as periurethral bulking. And on the right-hand side, those with urgency urinary incontinence, or to treat the urgency component of mixed, may be prescribed medications for pharmacologic management, may also benefit from the use of vaginal estrogen, and then may progress to additional advanced therapies such as chemodegeneration of the bladder and neuromodulation. This is an additional way to depict a bit more detail around this first line care. So again, we're saying that all types of these major subtypes flow into first line. On the left-hand side, we get a little more color around pelvic floor muscle training. So as we said, supervised training is truly identified as the gold standard. This has been described both with and without types of biofeedback, and has been demonstrated to have a 67% rate of cure or symptom improvement. This is something that can be scalable via digital health, group therapy, or unsupervised pelvic floor muscle training. And if you stick with us for the second in this webinar series, we'll talk more about some of the specific interventions and what they may look like. Patient education forms a very large component of this part of first line care as well. And you see that this is where there is some real skilled interventions to deliver the behavioral modifications that are helpful. Pelvic floor muscle training, as we said, is the cornerstone of first line care. And in bold on our first sub bullet here, you see the formal definition. So it is exercises for improving pelvic floor muscle strength, endurance, power, and or relaxation. And important to understand that it does reflect that these are different parameters of muscle performance and that one or all of them may be the target of a pelvic floor muscle training program. They are commonly referred to as Kegel exercises. But we're speaking of really the same thing when we say that. We've noted that these are the cornerstone of first line care. The effectiveness of pelvic floor muscle training truly is supported by very robust level 1 evidence, and it is embedded in the professional society guidelines as part of first line care for a number of both US-based and international organizations, only a few of which are displayed here by logos on the screen. So the American College of Obstetricians and Gynecologists, the American Urogynecologic Society, the International Urogynecological Association, the American Urological Association, and the American Academy of Family Physicians are just a few. There are often questions that arise around, well, how does pelvic floor muscle training work? Kind of it's become so commonplace that people have heard about it, but there maybe is not a lot of depth behind understanding some of these mechanistic reasons. So we thought it'd be really useful to just describe that the continence mechanism when it comes to the pelvic floor especially does rely on the action of the pelvic floor muscles. So there is a consistent and well-established way that the pelvic floor muscles will contract when they're contracting voluntarily. They produce a squeezing motion that compresses the urethral and the vaginal openings and also contribute a lifting motion, so a cranioventral motion that shifts the pelvic organs up and forward. And combined, these actions lift and stabilize the bladder neck, and they provide urethral support that helps to maintain continence. In stress urinary incontinence specifically, urine leakage happens when there is some type of activity or physical stress increasing pressure on the bladder and the pelvic floor. We know these common examples of coughing, sneezing, and laughing. And so normally as the bladder fills with urine, the pelvic floor muscles will be contracting involuntarily to help prevent leakage. And the pelvic floor muscles will kind of increase their level of effort and contract even more when there is an increased pressure on the bladder. So these muscles are lifting upward to support the bladder, compressing the urethra, and preventing leakage when there is some type of pressure on the bladder from above. And leakage then can result when the pelvic floor muscles are weak or not working effectively and responding in time. So continuing on this concept, so an adequate pelvic floor muscle contraction will work to counteract those increases in intra-abdominal pressure that occur from activities such as coughing and lifting, and that helps to maintain continence. Muscles can become damaged, dysfunctional, deconditioned, or weakened over time, and that impairs their ability to counteract those increases in pressure, which is why pelvic floor muscle training can be so beneficial. Urgency incontinence, on the other hand, it happens with a strong and sudden urge to urinate. It has a constellation of related symptoms. And as we start to think about how pelvic floor muscle training works here, it's based on the premise that normally when the bladder starts to fill with urine, the bladder muscle relaxes and allows urine to be stored. Stretch sensors trigger signals to the brain as the urine continues to collect in the bladder, and that we're able to work to control this urge through contractions of the pelvic floor muscles, involuntary and subconscious, perhaps at first, but that this is something that can be leveraged consciously and voluntarily to help by contracting the pelvic floor muscles to override the contraction that is arising in the bladder. So in the context of urgency incontinence or overactive bladder, those signals, that normal reflex loop between the contraction within the bladder wall and the contraction of the muscles get disrupted. So the bladder muscles may contract too often or too soon, and create a sensation within the woman of a strong or sudden urge to urinate that is not in proportion to the amount of urine perhaps in the bladder. And when the pelvic floor muscles are weak or they're not working effectively, they're really unable to participate as needed in this reflex process to suppress the urge, and bladder leakage can result. So training of the pelvic floor can work because the pelvic floor muscle contraction, as it continues to improve on all of those parameters described earlier, are able to effectively inhibit the bladder contraction and help to work to suppress the sudden urge, because the body truly does not want and will not allow both the pelvic floor muscles and the detrusor, the bladder muscle, to be contracting at the same time. So these images are just a depiction on both the left, kind of a blown out picture, and on the right, a little bit of a close up of the bladder control system. Just from a lower urinary tract perspective here, as urine is stored within the bladder, it exits through the urethra, and the urethra specifically is supported by pelvic floor muscles along its length. So we want to go back to just a moment, the evidence to support pelvic floor muscle training. We noted that it is strong. Incredibly large systematic review and meta-analysis has identified that there is a 67% symptomatic cure or improvement of urinary incontinence symptoms for any type of urinary incontinence. And that those numbers are even higher, 74% reported for stress urinary incontinence. Supervised pelvic floor muscle training, which we mentioned before, yields better results in the literature than unsupervised training. And the supervision definition is defined of at least 3 touch points with a healthcare professional over 12 weeks. Now, biofeedback may be used in conjunction with pelvic floor muscle training, but has been not identified to be superior to pelvic floor muscle training alone. Traditional biofeedback uses measurements that may be problematic and have some trouble providing accurate feedback, such as surface EMG. It picks up electrical signals from the muscles, but may pick up electrical signals from adjacent contracting muscles as well. And pressure paraneometry is squeeze pressure, typically measured intravaginally, that may have a risk of kind of misinterpretation through increases in intra-abdominal pressure. So despite a really strong and decades-long body of evidence for pelvic floor muscle training and professional society guidelines to support pelvic floor muscle training being a part of first-line care for incontinence, it's not been implemented broadly or at scale within the United States. As Dr. Kaiser mentioned, there are individual and institutional barriers to access. There are a limited number of trained providers who can provide supervised pelvic floor muscle training in accordance with gold standards, and that behavioral interventions can be difficult. They require motivation and a sense of self-efficacy on behalf of the woman who is executing them. And historically, there's not been a great way to track adherence to pelvic floor muscle training or to provide remote support. Beyond first-line training, as we've pointed out a few other times, there are advanced treatments that are effective and worthwhile to pursue. They vary according to urinary incontinence subtype. And certainly pelvic floor muscle training is something that may be implemented alongside these advanced interventions. We see from left to right for stress incontinence, again, highlighting the use of pessary, periurethral bulking, and surgeries. Mixed incontinence may benefit from either one of these types of interventions, as can vaginal estrogen be applied across the board. And then on the urinary urgency incontinence side, medications are specifically designed for that. They are not approved in the US for stress incontinence symptoms. And the use of Botox for chemodenervation of the detrusor muscle or other types of neuromodulation. The last slide here in this presentation just highlights a very recent publication that includes authors from our team and several of the graphics that have been used to depict the different elements of the care pathway for women with urinary incontinence. It's an open access document, including the infographic on the right-hand side. because we're seeking an opportunity to bring together the evidence to depict this story, kind of from all of the things that put someone at risk that can influence care seeking through the steps of treatment. The QR code there at the top will take you directly to the publication if you are interested. So that brings us to the end of part 1 in this series. If you would like any additional information, please feel free to email the address that's here on the screen. It's providersupport@renoviainc.com, and we would be happy to hear from you. Thanks.
Thanks.